Welcome to Raaonline. Today we are going to see about what is the current role of recruitment manoeuvres in patients with acute respiratory distress syndrome. So first, before going to discuss about the recruitment maneuver, we should understand about that how the ARDS lungs will behave, what is the underlying pathophysiology of that. So when you see here, the ARDS lung is very heterogenicity. It's not like homogeneous. When you as per the definition, there is a bilateral chest infiltrate as one of the criteria to define the ARDS patient. But when you do a CT in ARDS patient, when you see here, there is a lot of, you won't see the bilateral diffuse infiltrates in the most of the patient. You will see the most of the patient will have that some part of the lung will be completely collapsed, some part of the will be the poorly aerated, some part will be normal aeration. When you see here in these patients with ARDS CT, this part of the lung is consolidated. This is something is called that atelectasis. This is something is the normal lung. So in the same patient, that is a patient will have the different, some part is normal, some part is atelectasis, some part is consolidated. When you put a patient on mechanical ventilation, as that for the normal lung will go for the over distension. Atelectasis will go for the opening and closing. During inspiration it will open, expiration it will be collapsed. So all these problem, over distension or atelectasis, will cause the lung injury. So our aim of the mechanical ventilation is to not correct gas exchange, our aim is to achieve a safest level of gas exchange, gas values like PO2 and PCO2. It's in the safest level. The meanwhile, you have to avoid the lung injury, the mechanical ventilation induced lung injury. So when you see here, our aim of the mechanical ventilation to achieve the safest level of that gas exchange, to avoid the valve trauma, which is called over distension. Second is that avoid atelect trauma. It is that you avoid the repeated and closing and opening of the patients with ARDS. So why we need to mechanical ventilation? Why the patient is used to be very hypoxic in the patients with ARDS? First, the reason for hypoxia in the patients with ARDS is a shunt. What is shunt? If the patients is that where the ventilator alveoli are filled with or pus or blood or pus, whatever there are fluid, with the normal blood flow. If the blood flow is normal here, the aeration is not completely occluded, there is no zero ventilation, or it may be partially ventilated. So the ventilation is zero, the blood flow, the perfusion is normal. So in those conditions, what will happen that this shunted blood, this is a deoxygenated blood, because of the alveoli are not ventilated or there is not, it is a low ventilation compared to the perfusion. This blood is a deoxygenated blood. This is a normal alveoli. These alveoli are, if example is a non-dependent part, alveoli are normally ventilation. These ventilation, the ventilation have the normal ventilation, normal blood flow. When this deoxygenated and the oxygenated blood both will mix and will cause the hypoxia. So that is the problem with ARDS is that atelectasis and consolidation, which leads to the increased shunt fraction, which leads to the hypoxia. What is the second problem is that because of that our alveoli, if example this patient having this part of the lung is consolidated, this patient having more deaerated tissue. Because of that, if a deaerated tissue is decreased, the normal lung, for example, this is called the baby lung. This is called in this patient the baby lung. This part is the baby lung. So, for example, this patient have the higher baby lung, large volume of normal lung. This patient compared to this CT, this patient has the low, that available normal lung volume is low. So, if example, if lung volume is low, the complaints will obviously decrease. Okay. If the more severe ARDS, those patients will have the more complaints, poor complaints, or more elastance. The complaints is the inverse of elastance. If elastance is high, our complaints is low. So, if it is more alveoli are deaerated, our complaints will be very low. The patient will have the more pressure to open up the alveoli. The third one is the heterogenicity, which we already discussed. This means that because of that inflammatory edema in the ARDS, because of this inflammatory edema will cause the pressure, that is a gravitational pressure. This pressure and that heart and the sternum, chest wall pressure will increase the pleural pressure in the dependent region. Because of the high pleural pressure, this part will go for completely collapse or consolidation. Some part of the alveoli will go for the partially or poorly aerated. This part will go for the repeated collapse and opening. This is the normal lung, which is we call baby lung. Okay. What we will see here, the opening pressure. If you want to open this normal lung, we doesn't need that. Patient normally this lung will be open. Okay. This edematous wall will read a pressure of 10 to 20 centimeter to open this alveoli. This collapsed alveoli need 30 to 40 centimeter water. This consolidated means it is already filled with pus or blood or it is a secretion. You cannot open with the positive pressure because it's filled with the liquid or some solid material. So our aim is to open this edematous and the collapsed alveoli mainly. Our aim of the PEEP or recruitment maneuver or positive pressure ventilation is to increase the aerated tissue. So if aerated tissue increase, obviously your complaints will decrease, complaint will increase and the shunt will decrease. So the oxygenation will improve. The patient said the complaints is aerated tissue is increasing, that the homogeneous